lot of times less than 10% or 5% of people who are remaining as non-smokers or abstinent, at a year's time. And most people who quit have tried 7 to 10 times to quit before they actually succeed. So the most important thing is, if you fail to quit, try again. And it's usually those folks that are in their 7th time of trying that they finally then quit. So the most important thing is to have a variety of treatments for them to try. Okay, so if one doesn't work, try another. If that doesn't work, try another. So we need to have more tools in a physician's bag, so to speak, that they can offer to help smokers to quit smoking.
This is the Public Health Insight Podcast.
Before we move on, it is important to note that the views expressed in this podcast are our own and do not represent any of the organizations we work for or are affiliated with.
You're listening to the Public Health Insight Podcast, your go-to space for all things public health and global health, from the Sustainable Development Goals to the social determinants of health, as well as interesting dialogues about the diverse career opportunities that exist in these fields. Remember to subscribe to the podcast and leave us a rating on Apple Podcasts and Spotify so other people like you can benefit from our content. My name is Gordon, your host for this episode, along with my fellow co-host Will and our guest, Dr. Cindy Jacobs. Dr. Cindy Jacobs is an experienced executive in drug development with expertise in several indications and over 30 years experience in the biotechnology and pharmaceutical industry, achieving regulatory success in several product approvals. Dr. Jacobs received her bachelor's degree in microbiology from Montana State University, her master's degree and PhD degree in veterinary pathology, microbiology from Washington State University, and a medical degree from the University of Washington Medical School. Prior to joining Achieve Life Sciences in 2017, Dr. Jacobs has served at Oncogenics in various roles such as the Executive Vice President and Chief Medical Officer. Dr. Jacobs has also previously held positions as Vice President and in clinical research at 2 other biopharmaceutical companies. Based on her preclinical work at Immunex Corporation, she's one of the 2 inventors of the patent for Enbrel. Dr. Cindy Jacobs, welcome to the Public Health Insight Podcast.
Thank you for inviting me.
So first of all, that's a pretty impressive CV, so it's obviously nice to have you here. Did we miss anything? Is there anything else you'd like to share about yourself in terms of your career and background?
No, listening to it, it just sounds like a sordid past and history, but yes. So basically, for 2 decades, I was in cancer research, really trying to bring treatments to treat cancers to the market. When Achieve actually merged with Oncogenics, I stayed because they were more in public health and looking at smoking cessation. So I thought it might be best to try to prevent cancer instead of treating it. And so that's been an interesting 5 years with Achieve, and even other comorbidities, because smoking really increases your risk for heart attack, stroke, certainly COPD. So it's not just lung cancer. So it's really kind of taking the earlier approach, where I've spent decades on the end kind of result and trying to deal with it.
Exactly. And you're currently the Chief Medical Officer at Achieve Life Sciences. And can you tell us about Achieve Life Sciences and what you do there as a CMO?
Sure. So as the Chief Medical Officer, I'm responsible for the clinical and regulatory development for cytisinicline. Cytisinicline is a treatment for smoking cessation that is in the clinic. It's actually in phase 3. We can go into that. That's the latter stage of clinical development before approval. And this is an interesting product in that it actually has been a smoking cessation product in Central and Eastern Europe for decades. We're bringing it over into the U.S., as a new treatment. And we also then looking at expanding it in other places in Europe and worldwide. But right now we're focused with U.S. approval, because that's always helpful when you have U.S. approval then to expand it out with that U.S. approval. So we're a small group. We're focused on cytisinicline for nicotine addiction with our first approval for smoking cessation, but then also plans for nicotine vaping cessation, or basically a treatment for nicotine addiction.
Question about that. We often hear addiction and dependencies being thrown out there. Is there like a fundamental difference between the two? And if so, what are the differences?
Well, it kind of is kind of a range. Obviously, with nicotine, it's highly, you become highly and quickly chemically dependent. I mean, it's one of the, most addictive substances that you can use. It's up there with opioids. And so you quickly become what's called chemically dependent. Addiction for me is kind of at the very end, where addiction describes that it's affecting your life, that it's affecting your finances, because you're going to spend money to buy those cigarettes versus food. You're going to, because you can't smoke, you're going to then change jobs. You're going to work from home. That's kind of an interesting thing with the pandemic, by the way. So it's to the point that it's affecting your life somehow. That's kind of the end kind of stage of addiction, and it's there for nicotine as well as other substances that you can become addicted to. I can go into a little bit as far as the chemical dependency, to kind of go into that a little bit. So nicotine binds nicotine acetylcholine receptors in the brain, and when it binds, it elicits dopamine. So a lot of chemical substances that you get chemical dependency, they increase dopamine, other things. And so that's how that, when I call it chemical dependency, it's kind of down to that level.
It's a very interesting distinction. And I think back to one of our earlier points that you were talking about, Dr. Jacobs, about how smoking is scientific evidence and research has shown it to be one of the main risk factors for cancer and diseases, respiratory, heart, things like that. But I found it really interesting that you mentioned the social aspect of how smoking kind of seeps into an individual's life and almost takes over. So I think we've seen over the last few decades how there's been a real push towards smoking cessation, and a lot of the focus being on the health side. But what about some additional like social or environmental economic factors? Like, do you think there's like an overall societal impact as well that smoking brings?
Definitely. I mean, I think the CDC reported, smoking-related illnesses in the United States alone cost billions of dollars. I think the estimate was $300 billion each year. So there's a lot of cost to take care of the morbidities and the effects of long-term smoking. So that definitely has the social financial aspect of it. Now, the one good thing is that a lot of our health insurances basically pay for treatments for smoking cessation, which is helpful. So that shows you that obviously the cost of the insurances and the hospitals and everything for what are the morbidity and mortality of smoking is really still there. I think people think that smoking, it's been kind of reducing in society, and it has been. However, last year, it was the highest rise in cigarette sales. I'm sure it was due to the pandemic. It will be interesting to see what the statistics are in the next coming year or two, when everybody gets out of their homes and we have some back to normal life. What the statistic will see as far as the increase in smoking or even e-cigarette use.
Right. I have a question about that. The increase in sales, is that existing smokers smoking more, or is that bringing in new smokers, or a combination of both? What do you think about that?
I think it could easily be a combination of both. Obviously, if you're a smoker and you're under stress, you're going to smoke more. If you were a past smoker and you're under stress, you could easily have picked up the habit again. And then obviously, being under stress, starting smoking could also occur, but it's probably increased smokers smoking as well as sadly past smokers going back to the habit.
I remember earlier on, like when the pandemic first started, there were a lot of reports kind of predicting that the pandemic not only will have its own kind of health impacts, but it will also affect many other achievements in health and kind of successes that the global community have taken. Like we can kind of definitely see, smoking as a really good example of that. Kind of the decades work in kind of reducing the amount of smokers, or just the prevalence of that, almost kind of rebounding back. And I would say similarly, things like routine vaccinations and like all sorts of things. So yeah, I'm definitely looking forward to seeing post-pandemic and all the research that would go into that side of things, and just evaluating the true health and societal impacts of this health emergency.
To expand that, we are in the middle of our phase 3 clinical trials during this pandemic. And interesting enough, so we've been having smokers come on to our phase 3 trial, Orca 2. And interesting, during the pandemic, we certainly didn't have problems accruing smokers to the trials. Now, obviously we did at the very beginning, because this was really at the beginning of the pandemic when no one could come out and everything was shut down. So obviously that affected our enrollment onto our trials. But once it loosened up, we actually had a lot of interest, obviously, for people who wanted to quit smoking during the pandemic. Mm-hmm. Now, as you well know, with stress and smoking, it'll be interesting to see how trying to quit smoking during a pandemic might affect the ability to quit smoking or to stay smoking. And so our study will be compared, I'm sure, with previous studies where they were done when there wasn't a pandemic. And that'll be really interesting as far as the every trial has your treatment compared to just regular counseling and placebo. It's called the placebo arm. So the rates of success in quitting smoking in the placebo arm will be able to compare with other studies that use placebo arms in a similar manner, where those quit rates are non-pandemic versus pandemic. So a lot of interesting information is going to come out here probably in the next year or two.
You've touched on it throughout this conversation around the success of quitting. So according to the CDC, nearly 70% of people indicated that they wanted to quit smoking, but maybe 10% of that were successful. And you've made an argument as to why, the stress during the pandemic and other factors have made that more difficult. So perhaps it's an opportune time to even talk about cytisinicline, like where that fits in the whole smoking cessation space. So can you talk about traditional therapies that have been tried? You mentioned sort of the behavioral therapy aspect of it. Could you talk a little bit more about some of those other traditional medications that have been used, and what were some of those shortcomings of those medications?
Sure. So one of the things to keep in mind as I'm talking about the various treatments is that it's also been shown that it's a lot of times less than 10% or 5% of people who are remaining as non-smokers or abstinent, at a year's time. And most people who quit have tried 7 to 10 times to quit before they actually succeed. So the most important thing is, if you fail to quit, try again. And it's usually those folks that are in their 7th time of trying that they finally then quit. So the most important thing is to have a variety of treatments for them to try. Okay, so if one doesn't work, try another. If that doesn't work, try another. So we need to have more tools in a physician's bag, so to speak, that they can offer to help smokers to quit smoking. Now, currently, behavioral support and just supporting somebody who's trying to quit is an underlying important factor of the treatment. And most things, most of the treatments have that, some better than others, some you get support from the internet, but usually the treatments, there's kind of like two categories. One is nicotine containing, so it's kind of a nicotine replacement therapy. So to get someone to stop smoking, they're going to crave nicotine. We'll give them nicotine in another manner, like gum, lozenges, patches. I mean, there's a number of products that are out there over the counter that people can use. The problem with that is it's less effective. The interesting thing is when you chew a gum or you have a patch, the release of nicotine is slower in your system than actually taking it in and smoking through the lungs. So it's less effective for a lot of reasons. You're not getting that kind of immediate hit that you would with smoking. You're certainly having nicotine in your system to reduce the craving and the withdrawal symptoms that you're going to find when you suddenly stop your smoking. But it's really, that's why it's considered less effective, because it just doesn't work as well as when you smoke a cigarette. So then that's why you go back to smoking. The one nice thing about nicotine is as far as the safety profile, I mean, it's basically safe. It's not a toxic chemical, except for, it does have factors like it will increase your heart rate. It'll constrict vessels. There's a lot of things that, is a reason to get off nicotine in whatever form you're taking it. But certainly combustible cigarettes with all of the tars and other kind of components to it, taking nicotine replacement factor, it's a safe treatment. There are only two other treatments that are not nicotine based, and that's varenicline, which everyone knows is Chantix, and bupropion, which usually is Zyban. Zyban actually really was kind of repurposed for smoking cessation. It really is for depression. It was a treatment for depression by GlaxoSmithKline. And then it got the smoking cessation because it too was found helpful. Now, the mechanism behind that isn't really clear, other than it showed to be helpful. The problem is it too is less effective. It's about the same kind of studies have shown it's about as effective as nicotine replacement therapy. The difference there is it does have not the clean safety profile. There are components of that where obviously anything from dry mouth to, it does have a seizure warning. So that's where you need something safe to get people who in a population to quit smoking. You certainly don't want to be taking something that has side effects when you're already trying to deal with the withdrawal of nicotine. That kind of goes with Chantix. Now, Chantix is very similar in its mechanism that cytisinicline has, which I can go to in just in a minute. So it's more effective than nicotine and bupropion, and it's been shown in clinical trials that it's more effective. The problem is its safety profile. It definitely has problems with nausea and vomiting is actually what's called the dose-limiting toxicity for that product. But also, what folks have also complained about smokers is insomnia, vivid dreams to the point of nightmares. So it has its safety or adverse event profile, so to speak. And that's where right now what we need is something that's very effective but very safe. And that's where cytisinicline is actually a candidate for that, because it should be as effective as Chantix, but with a far better safety profile. And a phase 3 study that was done by Dr. Walker in Australia, actually the trial was compared varenicline and cytisinicline in the indigenous population, the Maoris in Australia. And it showed that it was as effective for that population. In fact, it almost was more effective. But where it was highly statistically significant was less adverse events than Chantix. So that's why we're committed to cytisinicline for getting it approved in the U.S., because we do think it is going to be, it should be effective and safe, and we're having to prove it in our phase 3s during a pandemic. So that'll be interesting data.
Yeah, that's very interesting. And I wonder too, if you mentioned that cytisinicline has been used in, I think it was Eastern Europe, and now we're talking about it in the States now. So is this a new drug? If not, why are we only now starting to see where this fits in the realm of smoking cessation?
Yeah, that's a good question. We get it asked all the time. And so cytisinicline has been marketed by a pharmaceutical company called Sopharma in Bulgaria. And they are really only interested in their market and Eastern Europe. And our founders of Achieve years ago got access of basically an exclusive license to develop cytisinicline outside of Sopharma's territories, because Sopharma just really wasn't interested in looking certainly at North America and other places. So when they brought it over to discuss with FDA, the problem is there's nothing like it. And so FDA, by default, said this is a new chemical entity. So when you're a new chemical entity getting approved, you basically have to start from ground zero. Now, the problem with cytisinicline is that since 1980, a lot of like the non-clinical studies, all the clinical studies were way back where there's a lot more standards now that you have to fulfill. And so we basically had to start over. And it was helpful with NIH and NCI and NIDA. They have actually helped us with millions of dollars in starting over. So we do have some assistance. NIH and NCI paid for and actually conducted a lot of the non-clinical studies that we had to repeat that allowed us to go and submit an IND. They also helped us with some of the non-clinical studies that we had to complete before we could even get into our phase 3 program. So that's been very helpful. But then we had to start all over in what's called phase 1, phase 2 clinical development before getting to phase 3. So if I can just continue, I can kind of go with phase 1. What did we have to do? Well, I mentioned that varenicline or Chantix, their dose-limiting toxicity was nausea and vomiting. Well, we didn't really know what our dose-limiting toxicity was because those studies hadn't been done. So we had to go and basically keep increasing the dose of cytosine until we saw adverse events that were severe enough that it was like, yeah, that's dose-limiting toxicity. The interesting thing is that our dose-limiting toxicity was nausea, but it was giving it at 10 times the doses that it was seen in varenicline. So the nausea and vomiting with varenicline or Chantix was seen at 3 milligrams doses. So that's why they only give 2 milligrams a day. We started to see nausea at 30 milligrams a dose. Well, our dose is 3 milligrams 3 times a day, and I'll get to that in a minute. So there's a huge, what they call, margin of safety for cytisinicline, and that's really where the benefit, I think, of this drug is going to be, its safety profile versus the other safety profiles. Now, phase 2, one of the things that the regimen in Eastern Europe was kind of a little complicated. It was, first of all, it was short. It was only 25 days. It started with 6 doses a day for 3 days. Then you went down to 5. Then you went down to 4, 3, 2. And then by the 25th day, you were taking 1 dose. And the dose was 1.5 milligrams, not the 3 milligrams. So with FDA, we kind of took advantage of like, okay, if we're a new chemical entity, let's go back and see if we can look at the dose, look at the regimen, and make it better, because we're starting at the beginning. Let's start at the beginning. To make a long story short, our phase 2 program showed that increasing the tablet strength to 3 milligrams and giving it 3 times a day, not 6, 5, 4, 3, 2, just 3 times a day worked. And it worked for 25 days. But we also listened to the smokers that were in those trials and the physicians, and they said, boy, this would be great if it was a little longer. It needs to be longer. So our phase 3 program is looking at 3 milligrams 3 times a day for 6 weeks, as well as 12 weeks compared to placebo treatment. And of course, everybody gets behavioral support in the studies.
Yeah, I was going to ask you then, so compared to something like varenicline or Chantix, or I think it's called Champix in Canada. So I believe Champix or Chantix is 12 weeks for the traditional treatment. So in terms of medication adherence, is there value in it being, that sweet spot between 25 days to 6 weeks? Do you think that would be an easier sell for patients compared to Champix at 12 weeks or more?
Well, one of the things we have looked at is that the majority of smokers don't complete the 12 weeks of Chantix. So we don't know whether that's due to the being tired of adverse events and stopping because of the nausea, bad dreams, or whatever. Or is it folks wanting to have shorter treatments because 12 weeks, you get, 12 weeks is like, wow, I wish this was a shorter treatment. So that's why we looked at, 6 weeks versus 12. If both work, it gives the physician an option to somebody who says, God, I don't want a 12-week treatment. Okay, I'll try the 6-week treatment. Or there might be those subjects who say, listen, I've tried to smoke 5 times. I'm going to take the 12-week treatment. It's giving smokers options. And if you give them options where it's been clinically approved by the FDA, then that means then insurance companies have to pay for it. So, that's where it all kind of comes together. Gives smokers options on what fits their lifestyle and what they want to do as far as a treatment.
Yeah, I think that's a really good point. And going back to what you said at the very beginning, it's almost like different tools in the bag, giving the patients the choice themselves to see which treatment fits them best and like their own circumstances, their own, behavior or just factors out there. So I had a question actually regarding the distinction between the nicotine replacement therapy versus these other forms of treatment. So for nicotine replacement therapy, like you mentioned, if you're replacing the smoking with something like a gum or like a lozenge, would it be a continual thing that you're taking, or will it eventually kind of result in the individual not having to take anything?
Well, obviously, now you're talking about addiction to nicotine. So there, I think we have family members or people we know that, still chew nicotine gum to this day. So coming off nicotine, you can still use nicotine gum as long as you want, and it depends on then how you wean yourself off that or don't. Interesting enough, FDA requires us to do kind of what's called abuse liability studies to make sure, and Chantix had to do it, and we're having to do it to make sure that you don't get rid of one addiction and then you're addicted to Chantix or Cessation, which obviously didn't occur with Chantix, and we're not seeing it with Cessation, but what you're getting at is like finally stopping. And that is also, you're really kind of now touching on one of the ways to quit smoking can be to vape, to actually go to e-cigarettes. And that's somewhat controversial. Clearly, if you can stop smoking combustible cigarettes and go to e-nicotine cigarettes, that's harm reduction just in and itself. However, it's going to be interesting in years to come on what are the long-term safety issues of what the liquids are with e-cigarettes or nicotine-containing e-cigarettes, because it is showing that in some of them, because there's so many different varieties of vapes and e-cigarettes, that A recent study in the Truth Initiative, I think, reported that heavy metals such as cadmium, lead, nickel, tin, and copper were detected in some of these various aerosols and in the liquids. So it'll be interesting to see long term just how safe that is. That's where it's kind of controversial. I think most physicians who are treating nicotine addiction still think, great, harm reduction, get off the combustible cigarettes, go into e-cigarettes, but then get off of e-cigarettes. And that's why we're also starting a phase 2 trial looking at can cytisinicline, or how cytisinicline can help vapors, people who are just into nicotine e-cigarettes only. Can we help them quit vaping as well? So that's where we're trying to apply cytisinicline really strategically with market approvals for both of these indications.
Awesome. So just for point of emphasis, you're not saying those who currently don't smoke should go and try vaping because it's not harmful. What you're saying is in terms of those who are already smoking, maybe at a high frequency, getting down to zero, vaping might be along that pathway, and we just don't know enough information about it yet compared to combustible cigarettes.
Yeah, so here's the problem where it can be worse is it's starting to become appreciated that sometimes in trying to quit smoking through vaping, you end up doing both. And that population is being found to be more highly nicotine addicted. You can imagine, because now if you couldn't really quit smoking, but now you're vaping on top of that, and you've got Juul and other things where you're getting a lot more nicotine for vaping, so your overall daily content of nicotine is even higher, which means you've just become more addicted to higher doses of nicotine on a daily basis. Now, that's the population that I think we're all worried about as far as having even more comorbidities and problems quitting. So you have to be careful in trying to improve one situation that you just don't make it worse. And for some, you know, that is happening. So harm reduction is stop smoking combustible cigarettes and try to wean yourself off of nicotine addiction in whatever form you have, whether it's, you're a dipper, you'd have snooze or whatever. It's like, just, this is where we're trying to position cytisinicline as a way of dealing and treating with nicotine addiction, no matter what source of nicotine you're addicted to. But you have to walk before you run. So our walking is, we'll get smoking cessation approved, then we'll go for vaping, and then we'll hopefully at that point be able to have that more broader label indication. Forward-looking statements. That's our commitment, milestone, and goal. Right. Forward-looking statements.
I think that point about harm reduction, I think it really speaks to the whole idea in public health. So it's very clear, and it has been for many years, that combustible smoking and just cigarettes and just a vast array of health risks that come with those products. And it's how can we get the patient or the individual who wants to quit to get off of those and into something less harmful, to ultimately work with them to get to that end goal of hopefully one day completely smoking cessation. I think that's definitely a question that I sometimes kind of reflect on. It's this idea behind these novel tobacco products, and especially these vapes. Like I always ask myself, is this a tool for harm reduction, or is it another avenue or like another marketing scheme by the tobacco industry to kind of make nicotine or nicotine-based products more, air quotes here, socially acceptable? And I'm not sure if you're comfortable kind of sharing your thoughts on that, but I'd be interested in hearing kind of your ideas.
I think I think the answer is yes and yes. Yes, as far as these products, there's certainly harm reduction from combustible cigarettes. But is it a way for, having somebody start vaping that isn't a smoker, I think you mentioned that, that's where, you're still, nicotine addiction is nicotine addiction. And we don't have an appreciation for the long-term safety of these e-cigarettes and the liquids and the chemicals in there. For an example, in I think it was 2019 and 2020. Do you remember it's called EVALI? It was the e-cigarette vaping associated lung injury that was really coming to, everybody knew about it because it was being so publicized, and I believe CDC reported there were 2,800 hospitalization and there was over 30 some deaths. And so everyone focused on where it was coming from, and obviously e-cigarettes was the first thing to be looked at. Basically the main reason, but they don't know if it was the only reason, was looking at something in the liquids. It was the vitamin E acetate and more THC containing vapes, but that was the main cause, but it wasn't the only cause. Well, those are the types of things that I think, we're going to find out, maybe later, what other things are in vaping devices, in the liquids, whether it's e-cigarettes or THC or whatever, that are going to be long-term harmful agents. So that's why there's so much concern in having adolescents get used to, Juul and other kind of vaping, because you're at such an age that, addiction. In fact, most of our smokers in our trials, they're 40, the mean age is 45, but they've been smoking since they're 16 and 18. So they got addicted when they were an adolescent, whether it's smoking or vaping. That's where I think the biggest social concern is, that we've just, be careful that we're not giving another avenue of getting new adolescents addicted to nicotine.
Yeah, and speaking of you mentioned forward thinking when you were talking about a couple key points there, and I was thinking about the burden of smoking, I believe, disproportionately in low and middle income countries, and you talked about it's easier from the US once you get things moving along. Once you finish the commercialization of the process, it's easier to bring to other markets. So I just wanted to hear from you where you think a more global distribution of this, and even whether more clinical trials are needed in different countries to capture those nuances in terms of how it might benefit those societies. So could you talk about that for a little bit?
Sure. That's definitely in the future. We actually have had discussions with the World Health Organization, and usually when they put kind of preferred products or development in the World Health Organization, it's usually because they've been on the market for decades and years. So we're not there obviously with the 3 milligram 3 times a day. Now we could at least look at that 25-day treatment, because that has been approved. So we might be looking at discussions of that. It's just too early right now for us to kind of figure out as far as how we would do that. But we have definitely been in discussion with the World Health Organization in that regard. We do have that phase 3 study in Australia with the Mallory's, where they used the 25-day regimen, but then they kept kind of a maintenance out to 12 weeks of just 2 1.5 milligram tablets a day. So we have to look at what kind of what would be appropriate for expanding out as far as cost, maybe lower doses, maybe the original 25-day. Those are all questions that we'll be probably having further discussions.
Dr. Jacobs, you spent a number of years in the biotechnology, biopharmaceutical industry, and I'm sure you've learned a couple of impactful lessons in your journey. So I was just wondering if you could share with us some of the biggest challenges you faced in your career, whether it's relating to the specific work of an organization, and how you overcame that.
Well, loaded questions. So I think as far as getting products approved, it's a long and complex process. I think working with the FDA is important, and to remember FDA's main concern is safety. Okay? Yes, you have to prove efficacy, because why would you get approval? But they are totally focused on safety. And that's where I think with cytisinicline we're having, for once in my life, maybe an easier process with FDA. But it's certainly easier with cytosine that has such a good safety profile versus my previous life where we're looking at chemotherapy and Bexar, radioimmunotherapy, which definitely has safety and adverse events. So it's a lot easier when you have a product that's effective and safe. So it's basically maybe not how you approach it is what you pick to work on. So I'm enjoying it right now as far as not having to constantly worry about safety, given like it's a chemotherapy drug or something that really is toxic.
So given what you've just shared, your life's work to date, what you're hoping to accomplish, what are some of your key take-home messages for our audience who either might be looking to go into a career in smoking cessation research from either a clinical perspective, public health perspective, or just a general audience listening who might be impacted by smoking? What are your key take-home messages for that?
Well, I think definitely anybody that's interested in addiction that's fabulous, because I think that really it's kind of a health kind of issue that is a lot of ways ignored, because that really, we do need more people that are helping and doing research on addiction, because I think it is really crippling society. So go for it. Definitely. I think for smoking cessation, if you're going to go in behavioral support, I think the most important thing is constantly having that try again. If you fail, don't worry about it. Try again. You will succeed. So it's kind of like that. Don't give up. Don't give up ever.
Thank you for listening to the Public Health Insight Podcast, your go-to space for informative conversations, inspiring community action. If you enjoy our podcast, be sure to subscribe and leave us a rating on Apple Podcasts or Spotify. See you in the next one.